My name is Geordy Clements. I'm one of the third-year cardiology fellows here. Going to give you a talk on acute coronary syndromes. This is going to be hopefully informal. I like giving it in person better, but feel free to interrupt me if you have questions during, or if you have questions after. Feel free to text me or doc-hail me or email me or whatever, and hopefully this will be informative for you. It's something you're definitely going to see a lot, so that's why we're trying to give some of these talks earlier in the year as opposed to some of the more specialized ones later in the year. So the plan for today, mainly just want to give a very brief introduction on ACS, acute coronary syndromes. I do want to spend a lot of time talking about some definitions because I was always confused what people meant. There's a lot of terminology out there that is not always necessarily consistent. So I wanted to spend a good amount of time just going over some definitions, and finally at the end we'll talk about what to do with your patients when you inevitably see somebody who comes in with ACS. This is the definitions you guys have probably most seen, like in med school and all, of acute coronary syndromes. It involves ST elevation MI, non-ST elevation MI, and then unstable angina. So breaking it down pretty simply, if somebody comes in with chest pain and you're concerned that they're having an acute coronary syndrome, you obviously look at the EKG first. If they have evidence of ST elevations, they then obviously have a STEMI. If they don't have ST elevations, you then look to see if they have elevated troponin. If they do not have ST elevations but do have an elevated troponin, that gives you an N-STEMI. And then finally, if you see somebody who has sort of the right clinical story, no ST elevations on their EKG, and then normal troponin level, we call that unstable angina. I'm going to give you a different way to remember these a little bit later, but this is sort of the basic stuff you'll see in textbook, and you guys probably all know this before, so I don't need to spend too much time on it. Just a couple of years ago, all of the sort of world cardiology societies came together and came out with this document. It's called the Fourth Universal Definition of Myocardial Infarction. It's kind of long, but it's actually really helpful to read if any of you ever get confused about any of the terminology. It breaks it down very simply, and it introduces two new sort of concepts, is the idea of myocardial injury versus a myocardial infarction. So I want to spend a lot of time talking about these definitions because for me, if you can understand sort of the definitions behind things and the pathology, it allows me at least understand the disease better and then figure out why we treat it the way we do treat it. So again, it talks about myocardial injury versus a myocardial infarction. First, I want to talk a little bit about myocardial injury. The definition of myocardial injury is just evidence of elevated cardiac troponin with at least one value greater than the 99th percentile of the upper limit of normal. So obviously in EPIC, that's when you see the little sort of red exclamation point next to your abnormal troponin. We'll talk about myocardial infarction later, but the idea of myocardial injury is relatively simple. It's kind of what it says. It's just there's some injury to the myocardium that causes a release of troponin. No cardiology talk is complete without talking about the troponin. So real briefly, the troponins are three different proteins that help regulate the interaction between actin and myosin. Here at university, we use troponin I, which is the most specific. The assay is the best. You shouldn't get troponin I from anywhere else in your body. Occasionally, some of the skeletal muscle proteins are similar to the troponins and can sort of cross-react. You'll see that mainly more with the troponin C and the troponin T. But here and most places use troponin I. The VA, about 9 months or so ago, switched over to doing a high sensitivity. I think it's a troponin T. So you will see that at the VA. But at least here in most places, you'll see troponin I. And I've never seen a troponin C assay before. As I mentioned, they're released classically during myocardial cell death or ischemia. But we now know with the advent of these high sensitivity troponins that there are lots of reasons people leak troponins. If you measure with enough sensitivity, you can detect just normal apoptosis, the normal sort of cell life and death that happens in the heart. We know that sepsis and other inflammatory states lead to increased permeability of the myocyte membrane, which can then lead to release of some troponins. And as I mentioned, with the advent of high sensitivity troponins, like over at the VA, tons and tons and tons of people will have evidence of elevated troponins. We'll talk a little bit about the different causes of that and what that means, but that's what you will see at the VA. The terminology is also confusing because even though we don't have a high sensitivity troponin here at university, the test we use is incredibly highly sensitive. It's just not quite as high as the ones at the VA detect. If you go tested a marathon runner, they would probably have elevated troponin T with a high sensitivity assay over at the VA. But just because our troponin I here isn't highly sensitive, it's still a very, very sensitive test. Briefly, I want to talk about some of the non-cardiac causes of elevated troponin. I put non in sort of quotes here because they all sort of, again, all troponin comes from the heart. So everything causes the troponin to be released from the myocytes. It just isn't what we sort of typically think of as the primary cardiac etiology. Everybody who's been in the MICU or everybody who will be in the MICU will see tons and tons of people with this. These people come in, they're critically ill, they're septic, they have neutropenic fever, sort of whatever underlying etiology they have that causes them to be critically ill leads to demand ischemia, which we will talk about another day, but that's a topic where you just get more, the heart can't supply enough demand for the stress the body is under. They now interestingly think that some of the inflammatory markers in sepsis actually directly cause a release of troponin, so it might not even be as much of a demand ischemia that we see in the MICU, but you'll see everybody in the MICU has some elevated troponin level. People with acute PE typically have elevated troponins. The etiology is thought to be hypoxia, hypotension, and then in severe cases, RV strain, which causes some stress to the myocytes leading to elevated troponins. Interestingly, stroke and subarachnoid hemorrhage leads to elevated troponin. So you don't see this on medicine as much, but if you do cardiology consults, we will sometimes see patients up in the neuro ICU who have a stroke or a hemorrhage. And the etiology is thought to be there is an imbalance of autonomic tone. So you get this dramatically increased sympathetic tone to the myocytes, leading to a little bit of release of troponin. The one I feel like we always talk about is renal failure. I feel like everybody always says, oh, this person has elevated troponins because they're not being cleared since they either have, advanced chronic kidney disease or if they have end-stage renal disease. Interestingly, I actually looked up in some of the papers what dialysis does to troponins, and it kind of depends, honestly. In some of the studies, it actually decreases the troponin by dialyzing them off. In others, the troponins increase after dialysis, which they think is due to hemoconcentration, and other studies showed no difference in the troponin level. But globally, people who do have renal failure have chronically elevated troponin, which is probably more due to the sort of chronic stress that they have on their heart. But you will very commonly see this on the wards. You'll see people who have a little bit of an end-STEMI, and then the troponin kind of just lingers for a long time. This graph, I think, is really important, and it differentiates two really important causes of elevated troponin. So you'll hear us talk in when people have acute MIs, which we're going to spend the rest of the day talking about. You see this big dramatic rise in the troponin. As opposed to people who have chronic myocardial injury, the troponin kind of just waffles. So these are the people who have a troponin of 0.029, and the next time it's 0.031, and then 0.03, and it kind of just hovers around there. If somebody's having a true myocardial infarction, they get these huge dramatic rise in troponin. So it'll be, might be normal the first time you check. A couple hours later, it's up to, 0.1. The next one you check, it's up to 5, and then it's 15, and then it's, 100. You get these huge exponential growth. So that's why we always talk about trending troponins is much more important than just a single solitary value. If you just pick one number and it's kind of right in the middle here, you don't know, is this person's next one going to be 10 times higher, or is it kind of just flat? So when we talk about flat troponins versus the sort of exponential upswing in troponins. And finally, again, this graph is from that fourth universal definition of MI. Just summarizes pretty well the different causes for elevated troponins. If you see that classic rise and fall, then it's normally due to ischemia. Some of these rare cases, advanced heart failure and myocarditis, we're not really going to talk about, but then the people who have chronically elevated troponins, or sort of the flat troponins, that's normally people with bad hypertension, or they have significant left ventricular hypertrophy or chronic kidney disease. They're kind of over on this other side. So again, anytime you have evidence of elevated troponin, sort of for whatever reason, you can say that this person has myocardial injury going on. But what we in cardiology obviously are much more concerned about is people who have a true myocardial infarction. So this is the fourth universal definition of an MI. It says that a myocardial infarction is due to acute myocardial injury with clinical evidence of myocardial ischemia. So you need the elevated troponin, which gives you the myocardial injury, and then you need evidence of myocardial ischemia. So what they define as evidence of acute myocardial ischemia is either symptoms of ischemia, EKG changes, or imaging evidence with a stress test or an echo or things like that. So symptoms of MI, I know all of you guys know this, but real briefly, we talk about typical angina versus atypical angina that we call non-cardiac chest pain. This is a very old school definition. I don't know if I put too much sort of sway into it, but typical angina should be chest tightness or pressure in the substernal area of the chest that radiates to the jaw or the left arm. Again, typically it's not sharp, so people who describe sharp pain, it's a little bit on the atypical side. The classic story is, somebody feels like somebody's pressing on their chest, or they just feel like there's a pressure. Some people actually don't describe it as pain at all. So you talk to these people and you say, oh, tell me about your chest pain, and they go, I'm not having any chest pain, it's more of a pressure. So just make sure you don't miss out on people who are sort of into the semantics more. Typically, angina gets worse with exertion or with stress. So when you're dealing with people more on a chronic side, some people say, oh, every time I walk up this hill by my house, I get a little bit of chest tightness. I rest and take a nitroglycerin, and 5 or 10 minutes, the pain goes away. We definitely want to know that if somebody's coming in with chest pain, we want to know, is this similar to the chest pain you've had in the past? Is it occurring only when the person is either under stress, emotionally or physically? And then does anything make it better? So classically, angina should get better with rest or nitroglycerin. And again, the formal definition of typical angina, you need to have all three of those criteria. If you have any of the two, we can call this atypical angina. And then if you have just one of them, we call it non-cardiac chest pain. Again, more of a chronic outpatient management, but we talk about angina in sort of three ways. The most concerning is rest angina, meaning the person is having anginal type symptoms at rest. This might be somebody who used to get angina walking up a hill or a flight of stairs, but now, they're just sort of sitting on their couch watching TV and they get angina. Angina should last for more than a couple seconds. So these people who come in with fleeting chest pain, that's very atypical. Real true angina lasts for 10, 20 minutes or so. You also get concerned with new onset angina. So I guess anybody who ever has had angina has to have a first time it happens. But if the first time and it occurs and it's very severe and they feel like it's physically limiting them, that would be very concerning for myocardial ischemia. And just progressive angina. So this is the person who used to be able to walk up that hill. Now they get halfway there and they get the same typical chest pain, or they make it to the top of the hill, but it now takes half an hour for the pain to go away instead of 10 or 15 minutes. All of this would be concerning if they were to come in to the hospital. Would be concerning for myocardial ischemia. Obviously, I know you guys all know this. Most people don't present typically. Looking at just some of the data, up to a third of people don't even complain of chest pain who come in with true myocardial ischemia. Classically, the atypical people are women and diabetics who present more atypically, but I've definitely seen people who come in with a big STEMI and they just complain of feeling a little bit tired. Sometimes people who get some inferior infarcts get these kind of nausea, vomity, kind of vaguely type symptoms. And then on the other extreme, some people, their first presentation of an MI is cardiac arrest. So these are the people, who you resuscitate down in the ER, you get an EKG after, and you see they've had huge ST elevations. So you think they might have had a STEMI as their STEMI leading to cardiac arrest as their presenting symptom. So the thing I want to spend a little bit of time about is these EKG changes. So again, if you remember our definition, in order to have myocardial infarction, you need to have positive troponins, and then EKG changes is one of those other things that you generally need to have. The one that we are the most concerned about is obviously ST elevations, and that, if you remember our initial diagnosis, that is what defines somebody's having a STEMI versus an NSTEMI. ST elevations, what we mean by that, it's an elevation of the J point, which I'll show you in a second, in 2 contiguous leads. And we're talking an elevation greater than 1 millimeter in all the leads except for V2 and 3. And in lead 2 or V2 or V3, women, it has to be greater than 1.5 millimeters. And in men older than 40, it's got to be greater than 2 millimeters. So if you guys all remember your EKGs, you obviously got your P wave, the QRS complex. The ST segment is from the J point, which is the change from the end of the S wave into where it goes back into an isoelectric aspect of the ST segment that should be at the same level as the PR interval. So this is the J point. So this is where you would measure. And again, if it's greater than 1 millimeter in any lead except for V2 or 3, or in V2 or 3 greater than 1.5 or 2 millimeters, that is what we would be concerning for a STEMI. These are the different sort of characterizations of what ST elevations look like. The most classic we see is these convex ones. And if you kind of remember, let's see if I can draw one here. Here, hold on. Let's see if you. So this is where if you kind of draw the face on the EKG, that person is very unhappy because they're having a STEMI. It sounds very simple. Somebody taught me that in med school, and I remember it. As opposed to some of the benign causes of ST elevations, I'll show you that kind of give you more of a smiley face. So this is the classic convex downward ST elevation that we're very concerned for. In these other cases, you sometimes see upsloping or horizontal. I've never seen ST elevations that are downsloping. So these first 3 are the ones that you guys are going to see the most commonly. The second part that you need to have to fit the diagnosis of ST elevations is you have to have an elevation in 2 contiguous leads. And what we mean by contiguous is they have to be in the same sort of geographic area. So if you all remember from your EKG, lead 1 and AVL are contiguous and they represent the lateral leads. Leads 2, 3, and AVF are the inferior leads. And then V1 to V6 are all of the anterior leads. We break it down further. V1 and V2 we call the septal leads, and then V5 and V6 kind of come back out to the lateral. Some people call 1 and AVL high lateral, call V5 and V6 anterolateral, but the V5 and V6 kind of bleed back out into 1 and AVL. So if you happen to just have a single solitary ST elevation in like lead V3, then you have one randomly in lead 2, that would probably not be a true STEMI. You have to have it, the elevations of greater than 1 millimeter in 2 contiguous leads. This is the natural history of ST elevations. So if you were to watch somebody have a STEMI, this is what would actually happen. Obviously, so this is normal here. So this is the J point. It's obviously very flat. Very acutely after they have a STEMI, the first sign you actually see is these hyperacute T waves. The only place I've ever seen these clinically is in the cath lab. You see this all the time when you're ballooning open stents and things. You're temporarily occluding all the blood flow. So people get these hyperacute T waves. But in real life, in the ER, if you have somebody in the hospital who's having chest pain, you're never essentially going to see these T waves unless you happen to have a 12 lead on the person as they're having the STEMI is just beginning. Because within the first couple minutes, this is where you get the ST elevation. So again, this is the J point we're looking at, and it's clearly elevated compared to the baseline over here. The next thing after the ST elevations people start to develop is the Q wave. So again, if you remember, the first downward deflection in the QRS complex is the Q wave. And the Q wave, as you can see, it starts to happen relatively subacutely. So we're talking like 4 to 6 hours or so. They might start, we call it queuing out. And that's a very bad prognostic sign. So if somebody comes in with ST elevations and these big Q waves, then it means they probably started having their MI, 6, 10, 12 hours or so ago. So they clearly have a worse prognosis than if somebody were to come in without Q waves. So sometimes you'll hear the terminology that somebody's starting to Q out, and that just means that the STEMI's been going on for longer than a couple hours or so. And then some people after their STEMI continue to have these Q waves. Other people, if you intervene early, they do not have Q waves. But if you ever see Q waves on an EKG, it probably means they've had a prior myocardial infarction in the past. This is, like as I mentioned, the typical non-ischemic ST elevation. So this happens commonly in young people. So If you ever just happen to have a young patient who gets admitted, check an EKG on them, and it's not sometimes surprising to see. We call this a sort of benign early repolarization. And again, if you do my little thing where you give this person 2 eyes and a face, he's much happier because he's not having a STEMI. This does not always work. You can sometimes you can be confused with things, but if you just remember this sort of I always mix up concave and convex. The concave up is generally benign versus people, who are having a true STEMI kind of have more of elevation like this. The other thing we always look for on EKGs, obviously you don't want to miss ST elevations, but ST depressions are very common as well in people who are having an MI. We generally get either horizontal, meaning the entire segment is depressed but horizontal. They don't have it on here, but sometimes you'll see upsloping depressions. That's generally less of a worrisome sign. If you have anybody who does like an exercise stress test, it's not uncommon to see what we call upsloping depressions. The ones that are the most concerning are the downsloping. So if you remember, if it's downsloping, it's kind of going downhill. That's how I always remember these people are generally not going to, it's a worse prognostic sign. Anytime you see ST depressions, you really, really want to look carefully to make sure that you don't also have ST elevations, because pretty much in every case of ST elevation MI, there should be reciprocal depressions. So if you ever see ST depressions, make sure you're not missing ST elevations, because we'll talk about the management, but the management is very different for a STEMI versus an NSTEMI. You can certainly have lots of cases where they have just ST depressions and no elevations, but you rarely see the converse of that. So if you have ST elevations, you're almost certainly going to have ST depressions. So anytime I see an EKG that has ST depressions, I go back and look again to make sure I'm not missing elevations anywhere. So again, back to our definition of a myocardial infarction, it's the evidence of myocardial injury, which is an elevated troponin with then these signs of myocardial ischemia. We talked about the symptoms, we talked about the EKG changes, and finally, we don't see this as much, but it's technically if you get imaging evidence of a new loss of viable myocardium, which is either a regional wall motion abnormality on an echo or on some of these nuclear stress tests. So if you get a nuclear stress test, you'll see up here, this area, if you guys can see the pointer, is down at the rest images is being perfused, up in the stress images is not being perfused as well. And you see it again here. And then more commonly, we do sometimes do an echo, where this is normal over on this side. So if you look up on this is the sort of anterolateral, anteroseptal wall up here, if you guys can see the pointer, that is moving well. And then here, it's kind of not moving as well. It's not coming together as a circle. So in the right clinical setting with elevated troponin, and you were to see an EKG like this, you could say that this person is having a myocardial infarction. So now I just want to go through a couple quick cases. I don't know if anybody can talk or not, but at least do spend a second, look at these EKGs and tell me what you think. None of these are dramatically difficult, just stuff you should hopefully be able to recognize. Does anybody want to be brave and volunteer and tell me what you see on this EKG?
If anybody wants to type their answers into the chat box as well, I can read them out.
Maybe some elevations in like 1 in AVL.
Yeah, definitely. And what about anteriorly too? So V2, V3, V4. So this is a pretty dramatic ST elevation. So this is obviously something you do not want to miss. And then what do you think about the inferior leads?
You see some reciprocal depressions and 3 in AVF as well.
Yep, exactly. So this is not a subtle STEMI. So this is something you certainly don't want to miss here. And again, if you happen to just see these depressions, this is where you want to look and make sure you're not missing elevations. In my relatively limited experience, sometimes people miss lateral elevations. So just don't forget to look in lead 1 and lead AVL. They're not very subtle here, but sometimes they can be a little bit more subtle in the limb leads as opposed to the precordial leads. How about this one? What do you guys think?
Someone says probably benign changes.
Yeah, exactly. You're exactly right. So again, if you draw eyes, this person's smiling. this is in a young person. I just found some random young person's EKG. It's also pretty diffuse. You would rarely have ST elevations this diffusely if it was a true STEMI. This could look more like a pericarditis picture in the right clinical setting, but this is the classic. They almost sort of call it a fish hook. You get this little notching of the J point here. This is very common in young people, especially young African Americans. So if you see this in somebody with chest pain, do certainly look. Feel free to call us if you're concerned. But this is likely not a true STEMI. What about this one?
Oh, nice.
So if you guys look up in lead 1, a little bit in AVL, and definitely inferiorly, these are ST depressions. So again, sort of this is the ST segment. It's supposed to be up here, but it's pretty dramatically lower. And you very clearly see it, out in these leads. So again, anytime you do see ST depressions, you really want to make sure you don't see elevations anywhere. I don't on this one. So this is just the pretty typical ST depressions that you would see on an EKG. So again, while this person is not having a STEMI, if they have a positive troponin, they are having, you can call it myocardial infarction based off of this EKG if they had a positive troponin. How about this? Any volunteers?
ABBB?
Yeah, exactly. So this was a trick. This is a left bundle branch block. So there definitely are ST elevations here. Like this is the ST segment, and it's very clearly elevated. But in the setting of a left bundle branch block, since you get dramatic changes with depolarization due to the bundle branch block, you're going to get changes in repolarization, which is the ST and T wave segments. So there are special criteria called the Brugada criteria that help you differentiate pathologic ST elevations from the normal ST elevations you're going to see in a left bundle branch block. We're not going to talk about that today. You can look it up yourself. It's Scarbosa criteria. I always mix the two up. But it can be very tough to tell somebody who comes in with a left bundle branch block, are they having a STEMI? The sort of older teaching was that a new left bundle branch block is a STEMI equivalent. Practically, I've actually never seen that happen in my 6 years of being here so far. It's mainly more of the story. If somebody comes in with a really, really good story and they do definitely have a new EKG, I would be very concerned for that. But I think it's not as commonly thought to be a true STEMI equivalent, a new left bundle branch block. Just the concern is could it be masking a STEMI? So if you do have somebody with a really good story and they have a new left bundle branch block all of a sudden, certainly call us in cardiology and we'd be happy to talk to you about it. But I feel like it's a little bit going by the wayside, that old idea that a new left bundle branch block is equivalent to a STEMI. And how about this? Any thoughts on this?
Get the one that you just said it.
So is this ST elevations here?
So this.
Yeah, it is. But this person's paced. You see the pacer spikes. So you can't. Same pacer spikes acts physiologically like a left bundle branch block. So somebody with a ventricularly paced rhythm, you really can't tell anything about the ST segment. So don't be tricked into thinking that your patient who's being paced is having a STEMI just based off of their EKG alone.
Make sure you
All right, that was enough for definitions for now, at least. I want to spend the last half an hour or so talking about the management of ACS. So again, just remembering our initial definitions. First thing you obviously want to look at is, do they have ST elevations on their EKG? If they do, they're having a STEMI. If they don't, they're either having an NSTEMI or unstable angina. But this is a graph, sort of a graphic. I want you guys to start thinking about MIs in this context as opposed to this way of just thinking, do they have ST elevations? Yes, it's a STEMI. No, then it's an NSTEMI if they have a positive troponin. So type 1 and type 2 is, again, it goes over this really clearly in that fourth universal definition of an MI if anybody's confused or wants to read more about it. A type 1 MI is kind of the classic MI, at least that we all think about. It's a MI caused by a coronary artery disease, usually an acute plaque rupture, which then leads to a platelet plug that leads to acute coronary ischemia. So this is kind of the classic MI that you always think of. We call this a type 1 MI. The one that is more commonly heard is a type 2 MI. Some of you might have heard this. Various people use the terminology more so than others. I like the idea of a type 2 MI. It's the same thing. It causes ischemia to the myocardium, but it's not due to a acute plaque rupture sort of coronary event. These people commonly do have underlying coronary disease. So they are certainly having a myocardial infarction. It's not saying they're not having an infarction. It's just the underlying physiology of why they're having that infarction is very, very different. I wanted to talk more about type 2 MIs today, but I ran out of time making the talk. It got longer than I expected. So hopefully I will have time to do another whole talk on type 2 MIs. These are the ones that you see way, way more commonly, especially on the medicine side of things. This is the patient, in the NICU, who arrested for half an hour and is, hypoxic to the 60s, and they have a troponin of 10. What do you do about it? But again, for the rest of the talk, we're mainly going to talk about type 1 MIs. So again, this is the classic person has coronary disease. They have a coronary plaque. The plaque then ruptures, and you get a platelet plug. If you want to think about it a little bit more simply, the people who have a occlusive thrombus, these generally are the people who have a STEMI, versus some people either have a non-occlusive thrombus or they have an occlusive thrombus, but then they can sort of self-lyse it themselves. And they have a little bit of, this is a patent lumen, so they're still getting a little bit of flow to the myocardium. This is technically classically the end STEMI, but they're the exact same underlying physiology. So again, I want you guys to start thinking more in terms of type 1 versus type 2. We're going to spend all day talking about the type 1. So you can certainly have a STEMI that's a type 1. You can have an end STEMI that's a type 1 myocardial infarction. Classically, we see a type 2 end STEMI. You could technically have a type 2 STEMI, which we're not going to talk about, but we're going to spend the rest of the day kind of over on this side. But do the next time you're having a patient who has an MI, just think in your head, do you think that this is due to an acute plaque rupture, or is this due to supply-demand mismatch, which is the hallmark of a type 2 MI? So the sort of 4 very basic principles for treating a type 1 MI, be this a STEMI or a non-STEMI. It sounds silly. The first thing you need to do is really you need to recognize that the person's having an MI. The sort of cheesy saying that time is muscle is very true, as I'll show you in a second here. Anytime you have a patient who has chest pain, get an EKG. It's very easy to get a little bit jaded a couple months in. You'll have some of these people who just chronically complain of chest pain. So, when you're on nights and it's 2 a.m. and you've been dealing with this chest pain all night, and now the nurse calls you and they have new chest pain. It is easy just to get an EKG. It's a pretty easy test. It takes like 3 minutes to do. It's very cheap and inexpensive. It's always better to err on the side of getting an EKG and it being stone cold normal versus you sort of sitting on somebody with chest pain until the next morning, and then you're in a lot of trouble while you missed the person having a STEMI all night. In the people who have a really concerning story, sometimes you'll get an EKG and it's totally normal. Remember, an MI is a very dynamic process, so the EKG is going to be very dynamic. Ideally, if somebody is having sort of stuttering chest pain, you want to check an EKG when they're having chest pain. And sometimes you will see these huge elevations when they're having chest pain, and then for whatever reason the vessel sort of lyses the thrombus and they get more flow, and the ST elevations go away. So if you have a very high concern for somebody, just leave the EKG stickers on them. I mean, leave the machine on them if you have if it's happening that quickly, and just have the nurse literally check an EKG every time they get chest pain. We are looking for dynamic changes as well. Logistically, if anybody ever sees ST elevations on an MI, this is not the time to call a cardiology consult and page us or something. A STEMI is a medical emergency, so this is when you call the cath lab. The best way to do it, day or night, is just to call Express Care, which is 81234, and ask to speak to one of the interventional cardiology attendings who's on call, and they will connect you in. With Doc Halo, lots of the times, definitely take a picture of the EKG and be ready to Doc Halo it to somebody, especially overnight if there's not as many people in-house. If you're concerned anybody's having a STEMI, please do call the attendings. Obviously, if it's something silly, don't wake them up in the middle of the night, but if you have a real concern, please do not hesitate just to reach straight out to them.
But
Sometimes we occasionally on consults get consults for people who are concerned or having STEMIs, and anybody who's held a pager before, sometimes you don't answer it right away. So if you're concerned somebody's having a STEMI, it's a very true medical emergency. Just call the cath lab at that point. The reason we sort of harp on this a lot is time truly is muscle. So this graph looks at it in hours, and then it's sort of a predicted mortality reduction, with 0 being the start of the MI.
like Nina said,
After about 4 hours or so, your odds of making any sort of change in their mortality is pretty low. So you really need to catch these people early on the curve. And obviously anything after 12 hours, you're not really going to have any benefit. We sometimes don't even go and open up vessels that have been occluded for hours or days or so. We also talk about door to balloon time. It's like a CMS criteria that we try to meet. It's anybody who has a STEMI. The door to balloon time means anytime they hit the door, so it's first contact with the medical system, be that if they walk in the ER or if EMS sees them. And then the balloon part is once they're not even in the cath lab, it's once the vessel has been opened, which takes 5 to 15 minutes depending on how complicated it is. So we very rarely ever get in-house STEMIs, meaning somebody who's like admitted to medicine for pneumonia or something who develops a STEMI. Classically, they come in straight through the ER, and the ER is very good at getting these people up to the cath lab quickly. But if you were to ever be, either working in the ER or here at the VA, we do get STEMIs who walk into the VA. Or if you ever get an in-house STEMI, time is very, very important here. So the door to balloon time is 90 minutes. You're supposed to have meet that goal of 90 minutes. And if you see here, if you're just 15 minutes over that 90 minutes, your relative risk of death starts to increase. So time is very important in these. And this is a great graph. It kind of breaks down the door to balloon time into something called onset to door time. So it's how quickly the person sort of shows up to the medical system. You get these people, who have chest pain for 4 hours before they come in, but kind of forgetting about that. Just looking at over on this graph on the right side, if you look at the door to balloon time, the green is 0 to 45 minutes. Their 1-year mortality is the lowest versus door to balloon time greater than 90 minutes is obviously dramatically twice as high, but even 15-minute increments. So if your patient's having a STEMI, if you can get them there 15 minutes faster, you are going to decrease their mortality by a couple percentage points. So time is definitely of the essence in a true STEMI. An end STEMI is obviously concerning, but if you don't see elevations, you have a lot more time to sort of sit down and think and talk to your team about it, consult cardiology. But prompt recognition of a STEMI is very, very important. I don't know if any of you guys ever learning about MONA anymore as a sort of medical treatment of MI. Stands for morphine, oxygen, nitrate, and aspirin. It's like the worst acronym in the world. I wish they would stop teaching this in med school. Morphine has been shown to worsen mortality in people who have STEMIs, probably because the people who are the sickest are the ones who get it. Giving people oxygen when they don't need oxygen also probably worsens their mortality. Nitrate and aspirin is the right thing to do, which we'll talk about, but I hate the acronym MONA. Please, if somebody's having a STEMI, don't give them morphine first and then oxygen and then nitrate and an aspirin. So if anybody ever learned this, just
I'm glad you came here first because I think before clinic.
the mainstay of treatment for any kind of STEMI or any kind of myocardial infarction STEMI or NSTEMI is essentially antiplatelet therapy. Since we talked about the etiology of these type 1 MIs is you have a plaque, coronary plaque, which is this yellow stuff. You have the fibrous cap, and then for whatever reason, the cap ruptures. So then, the blood is exposed to the interior of this plaque. Platelets then adhere to it. You get platelet aggregation, and then you eventually just get complete thrombosis of the vessel. So anything we can do to decrease platelet aggregation is going to be very beneficial for these people. The mainstay of all treatment is aspirin. You guys all know aspirin blocks the COX enzyme that is used to make thromboxane. Thromboxane is a potent stimulator of platelet aggregation. So anything you do to decrease platelet aggregation will be very beneficial. Anybody who you are concerned is having an MI, anybody who walks in the ER with chest pain essentially gets a full dose aspirin. So 325 milligrams PO as soon as you can. Ideally, you don't want to do enteric-coated aspirin. It has a longer time to absorption due to the enteric coating. And if you do really want to speed it up, you can have the person chew the pills. It makes the absorption even quicker. Rarely, but I have seen it, is you'll sometimes have people who don't have enteral access can also have STEMIs. So you can give aspirin rectally. It's 600 milligrams rectally. So again, any concern you have for an MI, unless they have a very, very, very strong contraindication, like, an active, intracranial hemorrhage, aspirin is the first choice. But since we know the platelet sort of aggregation and activation pathway is much more complicated than that, we now have newer agents. So these are the P2Y12 inhibitors. So they bind the P2Y12 receptor, which you can see in this complicated diagram is up here. And it mainly just it prevents the activation of platelet, which then leads to platelet degranulation and thromboxane, and it just worsens platelet aggregation. So these are the clopidogrel, ticagrelor, and prasugrel, which we're going to talk about here. Clopidogrel is Plavix. This was sort of the first antiplatelet other than aspirin that was shown to be beneficial in people with an MI. It was the CURE trial, came out almost 20 years ago at this point in New England Journal. We use Plavix a lot still, but the thing that you guys really need to know, which I didn't know until I learned this in cardiology, clopidogrel is a prodrug, so it requires a two-step activation in the liver before it has any functional antiplatelet activity. It's metabolized by one of the CYP enzymes, CYP2C19. So because of this, it can take a couple hours, if not up to 12 or almost a day, to have any functional activity when you give somebody Plavix. We know there's a lot of genetic variation in the CYP2C19. Some people are what we call intermediate metabolizers, which means it takes them even longer to metabolize the drug to its active form. And then some people are poor metabolizers, meaning they essentially cannot metabolize Plavix into its active form. So these people, you can give Plavix to and nothing is going to happen. So clearly those people don't do as well in a STEMI if they're treated with Plavix. So ideally, we don't love Plavix in the setting of a STEMI, just because, if somebody's going to the cath lab in the next 30 minutes, if we give somebody a drug that takes 6 hours to be active, it's not particularly helpful. The typical dose you'll see people on, the maintenance dose is 75 milligrams daily, but in loading, the classic loading dose is 300 milligrams once. If you ask the cath lab, they'll say just give them 600, and that's just to try to get therapeutic levels, even if the person might be a poor metabolizer. Hopefully 600 milligrams of Plavix would get you some antiplatelet activity. But because of that, we are moving a little bit away from Plavix. We are using a lot of ticagrelor now, which is Brilinta. Its study was called the Plato trial, came out about 10 years ago. It showed a decreased rate of death, MI, and stroke in people having an MI without worsening bleeding. It functions directly, doesn't need to be metabolized at all, and you get peak concentration in 1 to 3 hours, but in a couple minutes or so, you start to get some functional platelet inhibition with ticagrelor in just a couple minutes or so. The loading dose is 180 milligrams once, and you want to obviously give that as soon as the diagnosis of ACS is made. If it's a STEMI, obviously you're going to do that very quickly. And even if the person's having an NSTEMI, a type 1 NSTEMI, which you think is a acute plaque rupture NSTEMI, you want to give these people dual antiplatelet therapy, so aspirin and ticagrelor or Plavix. And then the maintenance dose is 90 milligrams twice a day. Prasugrel, I feel like people don't talk about as much, but just to be thorough about it, it is also a prodrug, except it is very rapidly metabolized into its active form in the GI tract. It works really well. It actually gets peak activity within 30 minutes, and it has stronger antiplatelet therapy than either ticagrelor or clopidogrel. The reason Prasugrel was dead was it was called the Triton-TIMI 38 trial, pretty old, 15 years or so at this point, that showed there was significantly increased risk of bleeding, especially in elderly and people who've had a prior stroke or TIA. And then it actually worsened mortality due to these increased bleeding complications. So for a while, Prasugrel was dead. About a year ago, prasugrel totally came back to life here. So this study came out just a year or so ago, New England Journal. It was called the ISAR React 5 trial. And it surprised everybody because it compared ticagrelor to prasugrel. And we, sort of knew that prasugrel was probably a more effective drug, but the concern was always with the increased bleeding risk. But this trial showed there was no increased bleeding risk, and it was significantly better than ticagrelor in terms of decreasing MI, decreasing stroke, and all-cause mortality. So I don't really know what the current role of prasugrel is. We've had lots of good conversations in the cardiology department about it. You can't use it in frail elderly people, especially people who've had a stroke. So it can be hard to use in a STEMI. If somebody's coming in with a STEMI, it can be hard to get a very thorough history. Did they have a stroke 10 years ago? So I don't really know what the current role is, but prasugrel is definitely back from the dead. So I think we're going to see it more in the next couple of years or so here. On the other side, instead of antiplatelet activity, we're also talking about anticoagulation. Anybody who's having an MI, be it a STEMI or a non-STEMI, should be treated with heparin or actually any anticoagulant for the same exact process. You guys all remember this from med school and things. When you have thrombosis, it's more than just platelets that are active in there. We generally prefer heparin. In some rare cases, we will use Lovenox, but heparin, as you guys all know, has a very quick on and off activity. So if the person's going to go to the cath lab, we rather than be on heparin, so that way we could pause it for a couple of minutes beforehand, just before they do an arterial stick. The downside of heparin is if you start a heparin drip, a lot of times the people don't become therapeutic for many, many hours. So if your patient's having a STEMI and you want to get them therapeutic very quickly, you need to give them a really big bolus of heparin, sometimes up to 10,000 units or so. And then obviously this is the order in EPIC. There's a great order set for ordering the bolus and the heparin nomogram. But all people who have a type 1 MI, meaning either a STEMI or an NSTEMI, which you think is due to an acute plaque rupture, should be started on heparin, as well as the dual antiplatelet activity. The third thing, which we're going to talk about more in the next lecture I give at some point for treating type 2 NSTEMIs, is sort of you need to assess their hemodynamics and then figure out how you can augment their hemodynamics in order to limit the amount of myocardial injury that the person is having. So this is a really helpful graph that we're going to, again, look at some other time in much more detail. But in everything sort of in cardiology, it's a balance between supply and demand. So in these type 1 MIs, it's the supply that's the problem. If you have a blockage in your coronary artery, you're just not getting as much supply. But in order to fix that, we're obviously going to talk about revascularization. But in the meantime, while we're getting ready for the cath lab, you want to decrease the demand as much as possible. So that means decreasing heart rate, trying to decrease afterload, and in some cases, you even want to decrease the contractility. Again, this is a lot more important for these type 2 MIs, the type 2 NSTEMIs. So, the person in the MICU, who's tachy to the 140s, they have no blood pressure. They're the ones who we're going to be more talking about this at that time. But for people who come in with a STEMI or an NSTEMI, a type 1, beta blockers should be given to everybody. If somebody's having a STEMI, you're not going to give them a beta blocker acutely because, as you guys all remember, it does decrease contractility. And some of these people are kind of either in cardiogenic shock from their STEMI or kind of teetering on the edge. So you certainly don't want to give a beta blocker in the first couple of minutes they're here, but within the first 24 hours, anybody who comes in with either a STEMI or a type 2 NSTEMI should be started on a beta blocker. It mainly decreases the myocardial demand, so it hopefully lessens the amount of ischemia that is going on. Nitrates, you guys all know, are also very commonly given in people with an MI. It leads to relaxation of vascular smooth muscle, which leads to vasodilation. You mainly get venodilation, which then reduces the preload, which then gives you less myocardial wall tension, so it just decreases the demand of the heart. And also the nitrates can directly dilate the coronary arteries, so if there is any vasoconstriction that is associated with the STEMI or the NSTEMI, it can help relieve that. So classically, this is the only good part of Mona is the nitrate and the aspirin. So somebody comes in with chest pain to the ER, they're going to get aspirin and EKG, and then they're going to give them sublingual nitro right away. The sublingual administration avoids the first pass metabolism in the liver, so you get very rapid onset within a couple minutes or so, but the effect is very short-lived. So if you have somebody who's coming in with an MI and they're having angina, you give them sublingual nitro and it works, and then a couple minutes later they're having pain again. That's somebody who would just start a nitro drip on, and you just sort of titrate it up until they are no longer having angina. And then chronically, you can switch to Iserdil or Imdor. Statins is a talk for another day. Everybody should be on a statin in cardiology, especially anybody who's had an MI. And then finally, I want to spend just a couple minutes on revascularization. Again, the whole pathophysiology of a type 1 MI is this plaque rupture with a thrombus. So the best way to treat that is with putting a stent in. So you balloon open the lesion, put a stent in so it doesn't restenose, and then you've hopefully fixed their problem. Fibrinolysis is never happened. I haven't seen it happen in 6 years since I've been here. It's just giving TPA and things, but we are clearly a tertiary care center. We should be doing PCI on everybody. They actually talked about starting to do fibrinolysis if COVID would have been just a total disaster here, and we actually had plans to start lysing people, but we luckily never came close to having to do that. But PCI is dramatically better in every sense of every study, every complication. The relative risk of PCI is much, much better than that of fibrinolysis. So I've never seen somebody get lysed. Hopefully I don't ever in the rest of my career as well. This is just a picture. This was from a couple of days ago in the cath lab. I know we're running low on time, but briefly, so this is the catheter coming up. They clearly went femoral here. So this is coming up the aorta, around the aortic arch. It kind of goes off the screen, and then this is the tip of the catheter sitting right in the coronary, right in the ostium of the left coronary artery. So this is the left main here, and as you guys can see, kind of right in that area, that stump is just where their LAD is supposed to be. So this is somebody who came in with a STEMI. I was trying to find their EKG. It never got uploaded. I had heard they had huge ST elevations all in the precordial lead. So V1 to V6, big anterior STEMI. Once you get in there with the catheter, you then put a wire. So this is a different view, but this is the occluded vessel, kind of right up in this area. You put a wire down the vessel, and then on top of that wire, you put a balloon, and then you stent open the vessel. And this is the end result. I took the picture at a bad time, but this is the beautiful, huge LAD, wraps all around the apex that was totally occluded. So clearly somebody like this with a big STEMI, time is myocardium. You would really, really want to get this person to the cath lab quickly. The last thing we're going to talk about is when do you revascularize people with an end STEMI? So again, they're coming in, they have chest pain, they have positive troponins, but they don't have any ST elevations on their EKG. And then you've sort of thought, is this a type 1 or is this a type 2? And you've sort of decided this is a type 1 end STEMI, meaning they did have a plaque rupture and they have some sort of thrombus in their coronary artery, but it's not an occlusive one, not to the point of causing a STEMI. So when do you revascularize somebody with an end STEMI? There are some cases where you can relatively emergently need to do it. So if somebody's in cardiogenic shock, you're probably going to call the cath lab and do that quickly. Some people with just terrible, terrible pain. So you have these people on nitro drips, you're giving them beta blockers, you're trying to decrease their blood pressure, anything you can do to change their hemodynamics, but they're still having chest pain. Sometimes we'll cath those people pretty quickly. But generally for most of the people, we need to decide, are we going to do what they call an ischemia-guided strategy or an early invasive strategy? And the way we figure that out is based off of these risk scores. This is the more common one. It's called the TIMI score. It looks at 7 factors. An easy mnemonic to remember it is America. So age greater than 65, markers, meaning do they have positive troponins? What's their EKG like? Do they have EKG changes? Do they have risk factors for CAD? Have they had pain in the past 24 hours? Do they have known coronary disease? And finally, are they on aspirin at home? The more points you score, the worse these people do. Their mortality in the next 30 days is dramatically higher. So if you ever are on PCS and you admit a patient with an end STEMI, just practice and go online and do this TIMI risk score and figure out what their score is. Generally, we say somebody's high risk if their TIMI score is greater than 3. So the people who are high risk generally go down this early invasive strategy. So this is the patient you might admit, on medicine who has a pretty good chest pain story. Your EKG might have some sort of non-specific T-wave inversions, maybe some subtle ST depressions, but nothing very dramatic. They get admitted to medicine. You start them, you give them nitrates, you start them on a beta blocker, and by the next day, if they're still having pain or even their pain's totally gone, but they have a very high TIMI score, this is somebody we would probably go ahead and cath relatively early. And by early, they mean within the first 24 hours or so. So this is not something you're going to call the cath lab in the middle of the night about, but this is something you'd, consult the cardiology team, and they would probably recommend cathing this person relatively soon. On the other end of the spectrum, if somebody is very low risk, meaning they're a score of 0, 1, or 2, these are people sometimes will decide just to medically manage. We think the risks of doing a cath and possibly putting in a stent might be lower than their risks of just having coronary disease and managing it medically. So do get in the habit of trying to do a TIMI risk score. I feel like we don't always talk about it blatantly, like say, oh, this person's TIMI score is 4 or 5, but all these things you guys should just have in your head, and the more factors they have, the higher risk they are for having a bad outcome. The other one that sometimes people talk about, which I feel like we don't use quite as much, is the GRACE score. This looks a little bit more at hemodynamics, looks at their heart rate, their blood pressure, their creatinine, and then the kilo class, which shows are they in any kind of heart failure. And the same thing, the higher risk you are with a GRACE score, the more likely we are to intervene if the person's having an NSTEMI. So again, that's all I'm going to talk about today. Mainly, that's the treatment. If there's one takeaway message, do try to get in the habit of starting to think about MIs in this way instead of the typical just sort of, are they having ST elevations? No, they're having an NSTEMI. There are lots of causes of elevated troponins. At some point, we'll talk more about type 2 NSTEMIs. But, for the treatment of a type 1, either STEMI or NSTEMI, it's all very similar. You first need to recognize they're having it. You then start them on antiplatelet and anticoagulants. You try to change their hemodynamics to the best of your ability in order to decrease the stress on the heart. And then finally, you revascularize them. If it's a STEMI, it's going to happen urgently. If it's an NSTEMI, it will happen at a later time. That's all I got. If anybody has any questions, feel free to ask. I'll hang around for a couple minutes. Or you can always doc Halo me, or I have lots of free time this year now, so I'll be around a lot more. So feel free to ask any questions, and I hope you guys all learned something today. Thanks.
Thank you so much for
Doctor?
joining us.
Yes.
Dr. Clements, my name is Alexan. I have a question.